Hey guys, Jess here from MoveEd. Today I wanted to go through and show you or share the clinical reasoning tool that I use in private practice or MUSC settings. Now, this was kind of created, I'm a really chaotic thinker, and I created this super early on just to see if I could help navigate and problem list some of the clients that were coming in a private practice setting. Now, I'm really mindful this might not work for everyone. Brains work differently, but I'd come from a neuro background and I really liked the way that the neuro clinicians did problem lists and they could rule in or rule out contributing factors to people's presentations, especially for normal patterns like gait and sit to stand and things like that. Using those kind of principles, we reversed engineered it for any MUSC setting. And I'd be really keen to learn how you apply this to your clients and if you've found it helpful, harmful, or things you've taken away from it. So this is something that we use at Move all the time. Now, it starts off with the ICF. So please, I did just hear a collective groan then from you from your computer screens thinking, oh my gosh, do I have to learn this again? It's something that a useful tool to think in terms of how clients might talk about some of their limitations. And also too, it really helps contextualize their experience, especially if you're working with a persistent pain population or people are coming in with more complex issues. People aren't simple. They don't just come in with an ACL and tell you, hey, I've done my ACL and this is what I need to do. So they're going to come through you with things like participation problems. So think about this framework. For example, someone comes in with back pain. Hey, Jess, I'm really struggling to bend over. I can't pick up my little person or my little child anymore. And I'm really struggling to get sleep and I'm really struggling to work and I can't play sport on the weekend that I want to. So breaking it down into participation, this will really help you nail in and zoom in on people's goals. So for someone like that, it's okay, let's get you back to playing sport. That's a really big participation level. The other things is, hey, let's get you back into your identity as a mum. And just have that in mind. One of the activities that they spoke about is I can't bend over and pick up my little person. So that's a really good activity breakdown that they've done for you. So we're looking at flexion-based activities is something that's a real limitation and it's stopping that client from being able to participate in their daughter's or son's life and also participate in things like sport and running. So that will give you a really good clue into goals and also it'll really help you circle back at the end of the session to then give really clear guidelines of, hey, this is why we're doing this so that then you can participate or you can then achieve these goals in future. By nailing or zoning in on one activity, it can take away some of the noise and pressure from you as a clinician. So just thinking, okay, I want to really see if I can symptom modify this one thing for this person and then clinically reason about what are the contributing factors that might be limiting them from doing that activity. Environmental and personal factors are also things to consider. And again, they'll really help colour a picture of someone in persistent pain. And those contextual environmental factors can be really, really, really important when it comes to making some changes with people with chronic and complex conditions. So put a pin in those, but also know that they can be really, really influential in someone's recovery. For example, a personal factor is maybe if that patient's partner had persistent lower back pain and had a really bad workplace injury and hadn't actually returned to work, then she might be really worried about, hey, is this what's going to happen to her? And will she, if she's also really struggling with her back, not be able to care for her family and do all the things that she does to cover for her husband who potentially does have a back injury as well? So knowing more about the person and other things that their biases, their beliefs and also their personal experiences might colour their rehab journey is really pertinent just to have it in the back of your mind as something that might be important for later. So once we have gone into that, then you'll create a blank piece of paper, So for example, we've got participation, my back pain stops me from being a mum. The activity that I want to is I can't bend over and pick up my child, which is a flexion-based activity. And then we're going to go and nail down and drill down into body structure and function. Now, this is a really, really fun one when someone comes in with non-specific lower back pain, because we're trying to give a patho-anatomical reason for pain. But it just might help you sharpen up your clinical reasoning and start to think of how you can accurately assess or symptom modify in a session. So we'll break it down into subjectively, what does it sound like? And then objectively, how can you rule it in or rule it out? Then the other things that I really like to put in to level up your clinical reasoning is to start to think of like specificity, so ruling something in, spin, and sensitivity, ruling something out, snout. These will really level up your clinical reasoning and give you confidence in some of the assessments that you're doing in the session. So down here, we would have our diagnosis formulation. So always when I'm thinking about writing this stuff down, I generally do it in the same type of order. And at uni, you would have taught to rule out red flags, then have a look at pain, potentially, joint range, strength, muscle activation, control, and then things like balance, dizziness, other weird stuff. We'll focus mostly at the minute on red flags. So back pain, for example, can be littered with red flags. You don't want to miss them. 1 to 5% of people will have a serious pathology when they come with back pain. So it's something that you really need to be thinking about when they're coming in. It's not everyone, but it is some people. And if you are practicing for a few years, you will see it, especially depending in the settings that you've worked in. Previously, I've worked in advanced practice ED, so this would be something that I'd always be listening out for, where in private practice settings, potentially not so much, but still just something that if your spidey senses start to tingle, you really want to know where you can objectively assess and then have confidence in the referral pathway after that. So things that we're worried about with backs is fracture or trauma. Now, this is what we would then do in the clinic is what does that actually sound like? And so it would be a moment in time, I had a fall from a height, or I got whacked with a stick on my back, something like that. There's a moment in time generally, and it's an incident. For malignancy, generally that might sound like I've got pain at night. And when I say pain at night, it's pain that is mechanically not modulated. So they cannot move to find a position of comfort. Their pain is waking them up and they can't get away from it. Unexplained weight loss, general malaise, and generally feeling off. Other things, a past history of cancer is generally increased risk of malignancy in the spine as well. Other things that you'd be thinking about is sepsis and infection, and that would sound like, hey, I've been really unwell. I had a trip to Bali and I had a really good time and I've been crook ever since. Something like that might be giving you, or your spidey senses might tingle and be like, oh, maybe there's a back infection, or hey, I got bitten by something and I've been really unwell ever since then. Other things that we're thinking about is like central spine. So you're thinking of your things like cauda equina. So that sounds like, hey, I've really struggled to empty my bladder or bowel when I'm going to the toilet. So they might be able to go or not be incontinent. They can be incontinent as well, but it's like the retention and they actually can't initiate the action. So sometimes that would be something I'd be really worried about. Pins and needles and numbness around the groin. And again, any incontinence or things like fecal smearing would be something just to really keep your ear out for, especially if it's a new presentation. And they've got persistent or they've got back pain at the same time. Other central or red flags would be thinking is central stuff. Again, probably not so much in a back pain population, but it might be something to consider for red flags in another presentation. And this framework is something that you can continually add or come back to depending on what the setting is. And then you can also look at cardiac red flags. So that might sound like a shoulder tip pain on exertion. Then what we do is we'd have the objective measures. So how you can rule in and confidently rule out these red flags. So if we come back to a fracture or trauma, If you have a spinous process palpation, that's how if it was tender on palpation, exquisitely tender on palpation, and range is also reduced, so two objective measures, then they would be tics. And then your pathway from there would be to rule in or rule out fracture with an x-ray, potential CT scan, and then referral back to GP or further management at ED. So that's kind of how you would navigate this. And you can do the prep work and write this out for each of the conditions that might be coming in. Again, I like to put it down into acute presentations and then insidious onset. And you brainstorm all of the things that it might sound like for a client, and then objectively how you can rule it in or rule it out. Okay, so now we would then go into pain. Sometimes this is a really tricky concept to apply, so we can skip this if it becomes too much. But the different types of pain drivers that we'd be thinking is nociceptive somatic, chemical, or like a type inflammatory pain. So that might sound like, hey, I'm really stiff and sore in the morning, but once I get moving, then I'm okay. Whereas somatic might be, hey, when I put my foot on the ground, it really hurts. So weight bearing, so it's mechanically modulated. Neuroplastic or centrally sensitized type of pain nociception could be something like really colorful language, like it feels like I've got a rip pop or a crackle. When people start talking about weird stuff, I'm thinking about nerves. And then depending if they catastrophize, how long the presentation's been there, I'm thinking more, is it neuropathic, like radicular, or if it's neuroplastic and centrally sensitized. So that's what they sound like. Now, in terms of ruling in and ruling out this different type of pain, that's when some of your psychometric outcome measures can be really, really, really helpful. And that's where you can apply those there. Or things like with neuropathic pain, you can test pain by doing straight leg raise for a back pain to see then if they've got a dermatomal or myotomal type of pattern. Other things with neuropathic pain, you can be looking at the integrity of the central spine by, if anyone has any pain below the gluteal fold, we'll be looking at power, sensation, and reflexes. And so that would be your objective measures to rule in and rule out anything that you think you need to be worried about or escalate care. Then we'd go into range. And so in range, I'm thinking, are they stiff or do they have way too much movement? Or are they fearful of movement? So they're kind of three things that I'd be looking at. Stiffness will sound like, I feel really crusty. That might be some language that people use. Or if someone's got heaps of movement, they might say, I just feel like I need to stretch, but I can never get it. And then they proceed to hands down, touch their toes and turn themselves into a pretzel. That might be someone who's like hypermobile. Or other people, you might ask them to bend forward, and they might be really hesitant to, but when you have a look at passive range of movement, there's no issues there at all, and there's no pain. So that might be telling you, okay, maybe there's a fear inhibition for stiffness. Sorry, guys. Other things that we'd be looking at is strength, and that's where we might be thinking about a muscle or a tendon. And again, they'd sound like different things depending on the presentation. Again, it's a bit trickier with the back. We'd be more looking at range. But just so strength would be really pertinent if someone came in with a hamstring strain and they would say, I feel like I've just got no power, and it felt like it went at 3/4 time. And you could be looking at muscle range, and if there's a potential tear or loss of integrity in the musculature versus a tendon, which a tendon might sound like something like a change in load, insidious onset, and hey, I've got really stiff and sore in the morning, and then once I warm up, I'm better. So each of these things, you'd go back to this and just say, write down all the things that it subjectively sounds like, and then you can write down your objective things about how you can rule in or rule out that diagnosis. So if we think about someone who's coming in with a potential hamstring strain, but you're not sure if it's a tendon issue as well, You could do some objective measures looking at hip range to see if there's stiffness or hypermobility at the joint. You can have a look at muscle activation to see if there's a loss of power. And then other things is, do they get better with an isometric contraction, and does that modulate their pain, which might be a way to then rule in or rule out a tendon issue. So that's kind of how I'd be thinking about that. Other things to see if this is a driver of pain is looking at people's proprioception, coordination, endurance. Now, this is a bit trickier and a bit more faffy, so this would be probably more applied into someone with a non-specific lower back pain. I think we've got to be really careful when we give someone a really clear driver of their pain that might be pathoanatomical, because I don't think that's actually accurate, but it might be something that they have a deficit in. So someone who's really nervous to bend forward and they haven't bent forward for ages might not have pretty poor coordination and control in a flexion position because they actually never get there. They also might have really poor endurance and not a lot of core or body strength because they've deconditioned because they're so scared to move, or they're in so much pain to move. So it's something that we would assess and then treat from there. Again, this template, we've got in here dizziness, because these are other things that someone might be explaining about, but we can rule in or rule out other things like red flags, but that might be a session for another time. I'm really curious to see how you guys apply this to your cases. I would love if you came to us with a case and we broke this down in this kind of setting. And then also too, would love to know how you go adding things like sensitivity and specificity to assessments. So for example, someone might come in with a stiff and painful shoulder. We're no longer going to be writing down ligament tests and special tests like that, because we know that they're not so special because their sensitivity and specificity is actually pretty terrible. But we could use some of these strategies to find out, okay, what might be a potential pain driver, and then how might we modify their symptoms by ruling in and ruling out a diagnosis. Yell out if you've got any questions. This can be a concept that we might have to have a few sessions on just so you can really nail and clean up your clinical reasoning. But I feel like by doing problem lists in the MUSC setting, it can really shore up and add colour to your clinical presentations. And also too, if you're putting it back into the ICF, then you're not going to be missing those really important things to people's rehab journey about what their participation goals are and what are some other environmental and personal factors that might actually change their trajectory of rehab and success. I want to know how this lands with you guys. Reach out, email us, or engage in socials to see how this fits with you. And then also too, I want to know how this clinical reasoning tool works on the ground. If you've got holes in it or if you've got questions, please, we are all ears and would love to help you level up your clinical practice. Cheers. Bye.